Good evening, everybody, and welcome to the last webinar of this series of ESSM statement. This will not be the last webinar of ESSM, but of this series of statements. And this evening we have two marvelous speakers, Javier Romero Otero from Spain and Leo Lowenstein from Israel. Both are directly involved in the writing of this statement. Before we will start with the webinar, I would like to ask our president, Carlo Bertocci, to say a few welcome words.
Thank you, Kobe. Yeah, thank you very much. I'm quite sad to say that today is the last webinar. It looks like it was yesterday when we started, and for me it was such a long way to do 8 webinars, and we've done all of them. And so today, really, it's also my big pleasure to have two outstanding speakers like Leo and Javier, and I'm sure they will enjoy our hour in the best way possible. I just want to keep a few minutes to just remind you our educational programs. First of all, this program has been planned and organized by Kobe and Giovanni. And so I need really to thank for the last time, but really from the bottom of my heart, because they've done a very good job. And I think that all of you enjoy these series of webinars in different topics. For some reason, I can't see today my slides, but it doesn't matter because I'm sure that there will be now one slide basically mentioning about our project about publications. And you know that we are dealing quite a lot, trying to make as much as possible good formats and good piece of papers on different topics, because we cover really everything about sexuality. And so we have 2 books already done, and we are planning to update at least one of them. The only thing that I want to tell you that we have a 3rd book already on market is the one on surgery. And I think this is particularly devoted to people who are dedicated to surgical practice. And so really I encourage people to have a look at that. And as you know, we will give this free on the website for all our ESSM members. The last things that I need to mention is with regard of educational is our surgical project that is already prepared, and it will be announced very soon, and it will start in next year, 2021. And this will be a very full project and program for everybody who wants to improve their skills in surgery. So please have a look at it, and I'm sure that everybody will participate. They will really enjoy it because it's a completely innovative program with a certificate at the end. That it is really the only program in the world that can produce a certificate that is not from the society, but is from an international recognized company. Now, I think that I don't want to take much more time in presenting our programs that you can find every moment you want. You can read more detail in our website. So I think Kobe can move on, and then again. Thank you.
Thank you so much, Carlo. And I would like to ask another important person to say a few words. Giovanni Corona, our marvelous scientific chair, who worked very hard together with the scientific committee and the sub-chairs on the statement and in organizing this webinar. Giovanni?
Thank you, Kobe. Thank you, Carlo. Again, I'm really proud about what we are able to do with a very group of friends in our society. So this project was a fantastic project, and this webinar series, it was very, very good. I think that this one was one on which we had more discussion, because there is a lot of discussion about the role of radio frequencies and laser for the women problems. But Javier and Leo and all their team were able to in some way find what is the evidence. So essentially we are tonight we are showing you what is the real evidence, not just a discussion related to this possibility for the treatment of women, not only sexual health, but maybe in some way general health also, including several aspects of women sexual function. So please again enjoy the webinar, and thanks again to Lior and Javier and all the ESSM Scientific Committee. Please, Kobi.
Thank you so much, Giovanni. I will try to be very short and explain to everyone a few rules. And the few rules are that you have on your screen the possibility to chat with each other, but you have also possibility to ask questions. You have a button with Q and answer, and there you can write to our speakers a question that you would like to know concerning this presentation. They will not answer the questions during the presentation, but at the end, there will be a possibility to answer those questions to you. If you want to chat with each other or send information to us or ask us something, please use the chat as well. And don't forget at the end of the webinar to give also your feedback. But last but not least, please remember that at the end of this month, most probably end of this month, all the webinars will be also available on our website, so you will be able to watch them again and to see the information. So now I will stop sharing my screen, and Lior and Javier, again, two marvelous speakers, and both of them work very hard, and I must say that the statement was not only one statement, but two statements, because the JSM asked us to have it divided for laser and radio frequency. So if you want to read the papers, these are two papers as well. So Javier and Lior, thank you very much for being with us and giving this presentation. And I'm sure that all the audience will enjoy this webinar. Okay, Lior, you can share your screen.
All right. Okay. So it's a great pleasure for me to be here tonight. I have to say that I'm very excited. This is the first time ever I'm doing a webinar. So I hope we will enjoy it together tonight. I have the great pleasure to work with Javier, who is also on the screen, and he's going to assist us during this night today. You know, before we get into the people who worked on this study, again, it's really a good opportunity for me to thank Carlo, the president, Kobi, the past president, and also Giovanni, the chair of the education committee, who really supported all this project, and with them it couldn't be established. So so this is a great moment for me to say thank you for you. These are the people, the members who worked on this two position statement that were published, as Kobi mentioned, in the JSM. And tonight we have Javier, who was the chair of this committee. So of course he will be also available for any further questions. I'm a urogynecologist, and I'm working at Rambam Medical Healthcare Campus, and since I have a lot of patients coming with different indications for treatment by laser and radiotherapy, therefore radio frequency treatment. So therefore, I was really enthusiastic to see the results of this study of this group, and therefore I think that tonight it's a great opportunity to share with you some of these results. If we look on the literature, it's very interesting to see that over the last 50 years, there is increasing number of publications about laser treatment. Over the last 5 years, most of the studies are about treatment, not just about dermatology, also for gynecological indications. And the reason for this is there are many devices that are being today marketed by the different companies. And as you can see, these are only some sample of the devices that you can find. And I'm sure that some of you also met some of these reps who came to your office and said, we have the best machine for you, and why don't you try it? So it's important for you to understand that to date, there is no energy-based device that has either FDA or EC clearance or approval for the treatment of vaginal laxity. Although many international agencies in a variety of countries have varying level of approval for a variety of clinical indications, but there is no still any clearance from the FDA for majority of the indications that are being advertised by these companies. You know, the energy-based techniques have become popular because this is a non-surgical treatment options for the tissue remodeling, and the technique that is being used is mainly for what we call vaginal rejuvenation. So what is vaginal rejuvenation? Today, it's mainly indicated for GSM, what we call also the genital urinary syndrome of menopause, for vaginal laxity, and also for stress urinary incontinence. This is mainly, it's becoming a hot thing is because there are not many options for treatment which are not surgical. If we are discussing about stress urinary incontinence, a lot of time we start with pelvic floor physical therapy, and if this doesn't work, we give a prescription for a different vaginal tightening product. But then if nothing works, so we send our patients for surgery. However, now there is a new modality, a minimally invasive energy-based device, either laser or radiotherapy, which is offered to be one of the options for treatment, which is non-surgical, for stress urinary incontinence, as I said, vaginal laxity, GSM, and we'll discuss about these things. I want you to understand again that these devices are different. We have from the laser, we have two types of laser. We have the CO2 laser, which has shown to elicit an inflammatory response that at the end cause the increase in the production of elastin and collagen. We have the Erbium-YAG which result in a rapid contraction of collagen fiber, leading to shrinking of the exposed tissue, followed by neocollagenesis. And we have the radiofrequency treatment, which has a deeper penetrative capacity within the tissue. It has a lower frequency and longer wavelengths, and it can be delivered, and it can deliver the energy extremely to the vulva, as well to the vaginal and to the vaginal mucosa and epithelium, and also to the lamina propria. And the rationale for giving the radiofrequency is again for tightening the tissue. So these are the two publications that has been published just recently by the JSM. As Kobi said, they asked us to write two different papers, one for laser and one for radiofrequency. But the aim for these two papers were to present and to provide a statement by the ESSM about this topic, emphasizing what are the current evidence and what are the conflicting issues that needs further clarification about these treatments. The methodology was using literature research by the different engines that are currently exist, the PubMed, the Web of Science, the Embase. You can see here the keywords that we have used, and all studies that were in English language. In between this year 69, I can assure you there was no even one study during the 70s or 80s until July 2018 were included, and all studies had to have at least 15 patients in order to be included. We divided our research in order to make it for clinicians more easy to understand and also to get their main outcome measure. And we divided the classification to preclinical, to GSM, vaginal laxity, and these are the different indications. And the first thing that I'm going to start is to show you some of the preclinical research that currently exists about how does it work, and whether there are really some histological proof for neocollagenesis and changes in the tissue that may support the feasibility of these treatments. So just, I'll give you one example of how it's being published before about the erbium-YAG, what is the mode of action, so you can really understand why people can, why research thinks that it works and the way they think that it works. So erbium-YAG, it's a non-ablative smooth mode of thermal effect, and it works on the vaginal tissue by stimulating collagen remodeling and the synthesis of new collagen fibers. The way it works is by heating the tissue. There is a proper dosage of smooth mode of temperature in the mucosa, and in order to have the effect, it needs to reach a temperature of in between 60 to 63 degrees. This is the optimal temperature for the process and to cause the shortening of the collagen fiber, and then hopefully to cause neocollagenesis. Of course, it's not just about the energy. The energy is a sum of the time multiplied by the power. I'm not going to get into physics too much, but you have to understand that the different studies that we are going to read, it's very important to understand what was the power that was used in Watt and for how long the tissue was really exposed to this power, because the collateral damage or the depth of the damage or the effect of the heating is really correlated to these two parameters. So if, for example, the length of time is longer, then the collateral damage would be higher. Unless if the Watt is very high, the power is really high, then the depth will be higher. So this is important to understand. And when you read in the future about a study, it's important to see these parameters and not just giving a protocol of laser therapy or radiofrequency, because then you cannot compare one study to the other. The mechanism of the action that is attributed to the laser therapy is first having the photothermal interaction, then the thermomechanical interaction, and then the growth of the new collagen fibers. The exposure of the vagina needs to be fully exposed. The vagina needs to be fully exposed, and the way it can be done, it's either being done mechanically. Today there are robotically, which works, you know, the rotation is not by the human hand, but overall it's the same thing. The whole vagina needs to be exposed in order to have the effect along the whole vagina. There are 5 different phases. The first phase is the immediate shrinkage after laser radiation, and this is because of the heat. Up to 30%, the vagina can be shrinked, and this was measured by different studies. The second phase is the edema. It occurs about 1 to 2 days. About 100% of the patients following this treatment will have an edema reaction following treatment. And this is something that the patients need to understand. The third phase is the neocollagenesis, generation of new fibers. It occurs at about 4 to 6 weeks until about half a year following the treatment. The fourth phase, it's a stable period of shrunk and a new generated fibers. It's about 1 year or more even. And then there is a gradual decrease, and therefore laser therapy or radiofrequency, it's something that needs to be maintained. And it's not one treatment for a whole life. It's need to be maintained, and extra treatments need to be given in the future. So, following reviewing the literature, this was the first statement regarding what is currently known about the preclinical studies. And as you can see, the statement says that there are limited evidence suggests that laser and radiofrequency to the vaginal application have a different histological effect on the vaginal mucosal layers. The depth of the penetration, the duration of cellular response, and the exact underlying mechanism of action remains mostly unclarified. So this is mainly because the protocols are not standardized. There are not enough big studies to demonstrate it, that the attributed effects that I demonstrated before, and I showed you in the previous descriptive slides, results in this really outcome that we're looking for. In the next slides, you'll see some of the slides, but this is really sporadic evidence, and it's not enough to conclude that these are really, that this is a consistent effect that can be attributed either to the laser, one of the type, or to the radio frequency. How about clinical implication? The use of vulvovaginal, the use of laser or radio frequency for GSM syndrome. So first of all, let's say, what is GSM? GSM, and this was a terminology, it was published by the ISSM. GSM compromises a constellation of symptoms and signs associated with decreased hormones levels that can involve the labia majora and the minora, the introitus of the vagina, the vestibule, the clitoris, the vagina, the urethra, and the bladder. The urogenital atrophy or atrophic vaginitis is a condition that results due to the decrease in the estrogen level in the urogenital tissue. And this is what finally results in this syndrome that is mixed symptoms of both from the urine systems and also from the vaginal systems. GSM can occur at any time in women's life cycle, but in most cases, it occurs in postmenopausal women. About 50% of elderly patients report to have some of these symptoms. So the laser therapy, when was tested for treatment of GSM, we can see that there is no RCT, there is no even one RCT that has compared the laser therapy with other intervention. Most of the laser treatments that were given were by the CO2 laser, and there is a persistence of beneficial effect which resulted from having this laser therapy over a period of 1 year. The way it was assessed, it was mainly by subjective outcome measures that are the patient's reported scoring symptoms by visual analog scale, and also by VHI score, which is a score that assesses the vaginal looks following this treatment, and by the fluid, the elasticity, and also by the epithelial integrity. So if we look on these studies, there are 5 different studies. You can see the number of the patients and the follow-up, and you can see that most of these studies, or all of these studies, demonstrated a significant improvement in symptoms. Yet majority are prospective case series. There is no sham control arm, no placebo, and the follow-up is relatively short, and often safety or adverse effects are not reported in this study. And this is also something which is important to mention. With regards to radiofrequencies, the evidence regarding the use of radiofrequency treatment is also lacking. There are some reports demonstrating that there are positive outcomes in these studies, but again, these studies are suffering from small number of patients, as you can see, and also the period of follow-up is very short. One study has only 1 year, and the other study only 3 months, which is very, very short. And this is something that it's hard to conclude from this study. So overall, this was a conclusion from assessing the different studies. There are prospective case series studies suggest that laser vaginal application may result in a short-term objective and subjective GSM sign and symptoms improvement. But currently, there is insufficient evidence to support the use of radiofrequency vaginal application for the treatment of GSM. These are some slides that I want to share with you and to show you the effect of having this laser treatment to the epithelial of the vagina. And these were taken from patients, and it's hard maybe to see because it's not very small, it's not very big, but you can see here that there is that the stratified squamous epithelium is more pronounced following treatment. You can see that there is increase also in the papilla of the stratified squamous. You can see here the invagination. Unlike before treatment, you can see that it was quite straight. And also vasodilatation. I will show you 3 more slides before and after so you can maybe see it better. A is before, B is after, and here you can see some of the reactive changes of the epithelial. You can see the increase also in the cellularity. There is acanthosis following treatment with laser. This is another histological study of the vagina before and after. Again, this is before, this is after, and you can see the reactive changes in the epithelium. You can see the vascular buds that happens following this treatment with the laser treatment. And this is the last slide that I want to share with you before and after. Again, you can see the increase in the number of the fibroblasts. Here you can see the increase in the number of the fibroblasts and cellularity of the epithelium following treatment with laser treatment. How about vaginal laxity? Vaginal laxity, it's commonly defined as a patient-reported condition. The most problematic thing here is that there is lack of standardized criteria for diagnosis of vaginal laxity, of the severity, and how to grade the severity of vaginal laxity. Currently, there is no expert consensus on how, on the subjective and objective parameters that can be used in order to characterize this condition. With regards to the laser treatment for vaginal laxity, which is very, very popular in some of the countries, I know that in my country it's very popular, and also in some of European countries. The articles were highly heterogeneous regarding the use of the laser. You can see that the criteria for assessment of vaginal laxity were not consistent. Some use patient-reported symptoms. Some use perineometry, which is a way to measure the change in the tolerated pressure in the vagina. And also the period that these patients were followed was also very limited, in between 2 to 6 months. And here are the studies that you can see that though 3 out of the 4 studies demonstrated a significant improvement, yet the number of the patient is limited. The period that these patients were assessed was also very limited. And also the way that they were assessed was very limited. About radiofrequency, all studies reported a subjective improvement. The follow-up was never more than 12 months, and radiofrequency treatment was found to be safe by these studies and well tolerated. And these are the studies and the different tools that were used by the different studies. And you can see that all studies reported a significant improvement following the use of radiofrequency. Again, the period of assessment was following 1 month, 6 months, and only 1 study was for 12 months. So due to the lack of uniformity, of uniformly accepted definition of vaginal laxity, we cannot draw really a specific recommendation regarding the role of any energy-based vaginal application device in the treatment of this condition. Okay. Wait, okay. The next indication is stress urinary incontinence. And again, stress urinary incontinence, the use of laser for treatment of stress urinary incontinence, which is a well-defined objective and subjective symptoms. You can see that there are no RCT. The studies that that assessed the outcome of laser treatment for treatment of stress urinary incontinence were very heterogenic. Follow-up was also short, relatively short, 6 months. You know, if you do study following a surgery for only 6 months, you can never, it's not going to be accepted for any kind of publication unless you want to report about the poor and adverse event, because if you want to assess a surgery for stress urinary incontinence, it needs to be at least 12 months, if not more. Patients' reported outcome were mainly the different questionnaires, and you can see that from the 3 different studies, though 3 of them demonstrated a significant improvement and change, using the urodynamic as an objective tool didn't demonstrate any differences in these patients. So there is no any objective proof to see improvement following following the treatment with laser for stress urinary incontinence in female. What about radiofrequency? There are very few observational studies. 60% of the patients reported substantial improvement in symptoms following RF treatment, and the treatment were reported again to be well tolerated with no adverse event. Yet again, the periods that these patients were followed was very limited, restricted, and you can see that all studies demonstrated a significant improvement in this outcome. Yet one thing that you need to understand that when we discuss about objective symptoms, so to discuss about statistical improvement, this is something which is it's something that we cannot accept today in our literature, because objective symptoms needs to be a clinical improvement. And if it just with the numbers to see that the score was improvement, but patients were not more satisfied, it doesn't tell you much about the effectiveness. Or on the contrary, you can say, well, maybe the questionnaire tool demonstrated an improvement, but we want to know if the patients felt better, and this is much more important. And this is about clinical significance in compared to statistical significance. So with stress urinary incontinence, there is only preliminary data suggests that the use of laser or radiofrequency vaginal application can improve mild to moderate subjective symptoms of stress urinary incontinence. Last but not least, sexual health. With using the laser, there are few studies. Again, shocking, but again, they were very heterogeneous. I have to say that none of these studies were given as a primary outcome. These studies were the sexual health was a secondary outcome of this study. For the assessment of sexual health, they use the FSFI, a well-validated questionnaire, and patients reported an improvement mainly in sexual pain domain when using the laser. And you can see here the 3 different studies. The significant improvement was only in the pain domain, and in the other in the other 4 domains, there was no any improvement. About radiofrequency, there are more studies. Again, the FSFI was used. And in these studies, the improvement was mainly for the orgasm domain and the arousal domain following the treatment, and there was no effect for the pain domain. And these are the different studies that you can see. They are quoted here. And as I said, while the laser was for pain, radiofrequency's improvement was mainly in the orgasm and arousal. So the preliminary evidence derived from secondary endpoints, as I said, they were not powered to demonstrate any difference in sexual health, yet they demonstrated that laser vaginal application may mainly improve sexual pain domain, whereas radiofrequency may increase arousal and orgasm domain. Safety. With regards to safety, we have to say that they seem to be, based on the studies that reported safety, adequate safe profile of laser and radiofrequency application. It needs to be further assessed through well-designed, short and long-term sham control RCT. The study that reported on safety were again very limited in their reports, and the follow-up was also for very short. But if we look on the adverse event, as I said, 100% of the patient will have edema following the treatment. Pain is in about 7%. Superficial burn is also very rare. Bleeding also can occur. Vaginal discharge and de novo urgency incontinence, all these things can happen. So in conclusion, things that research in clinical setting is still poor, and this is how it was published in the JSM. A consensus should be reached in the terminology. For example, regenovation seems to be just a trademark. Everyone can use it for a different terminology or for different indication, and this needs to be better stated. Patient-reported improvement, we need to have RCT or blinded studies. The assessment should be validated using a homogeneous tool. As I said before, there are no serious adverse events. And of course, this literature and also our publication has its own limitation because of the search strategy. Our summary was that results currently from observational studies are encouraging. The effect of laser treatment appears to be comparable to that exerted by local hormone treatment, and therefore it can be indicated for patients with, for example, postmenopausal women who are suffering from JSM but cannot take hormone replacement treatment. Vaginal laser treatment may be appropriate for women, as I said, who cannot take the hormone. And this is just to show you a statement which was published by a different group in 2017, a consensus by some experts from the field. And they also said that the consensus has been reached among the authors of this study that the clinical effectiveness of energy-based therapies on JSM-related symptoms is something that needs to be taken into account, mainly in cancer survivors, and this was their publication. And I like very much the way that they finalized their study and what they said, that data generated from the unprecedented wave of publication in peer review journal on cell activation and vaginal wall regeneration following exposure to energy-based device justifies the caution. You can fool all the people some of the time, and some of the people all of the time. But you cannot fool all the people all the time. And this was a quote from Abraham Lincoln. And I think that it summarizes well these issues that needs to be further investigated and more research is needed. So thank you for your attendance, and we're looking forward to hear your questions.
Thank you so much, Leo, and Javier for this marvelous overview of our statement. And we have now time to have some questions from the audience. So, Leo, are you able to see the questions? Or shall I bring it to you? Okay.
In the chat?
No, in the questions, but I will read that everyone can hear that. This is an excellent review of the literature. I will be interested in Leo's personal opinion and preference. Has he used both, or would he prefer one over the other?
Is it about, the question is about the different types of laser or radio frequency?
As he stated in the question, the laser of the radio frequency, and if you have a personal experience and personal preference.
Well, I have to say that currently in my department, I have 2 different devices. We're doing a study, an RCT study about comparing between the CO2 laser and the erbium YAG for stress urinary incontinence. And currently I don't know the answer which laser is better. So I think for each indication, different type of treatment can be better or should be chosen. So there is no one treatment for all the different indications. It doesn't make any sense for you. Like for different problem, you have different modalities of treatment. So so we really need to have more literature to identify which treatment would be best for each indication. And I know that, for example, for stress urinary incontinence, there is more literature using the CO2 lasers than the erbium. So maybe it's better to use the erbium, but for GSM, it might be the contrary. So there is no one good answer. Javier, if you want to give a comment, what is your experience? So be happy to hear.
Hello to everybody. Thank you very much, Lior, for your wonderful presentation. Very good level, and thank you for your generosity always when I am working with you, because you are the real leader of this review, you and your team. Thank you to you and to Rao for your generosity in all the time we have been working together, and also to Kobe and Giovanni that has been doing a great work. I am andrologist, and I don't see a woman in my clinica. So I would like to ask you a couple of questions, Lior, if it is possible. My first question is that when we were doing the review, there were no definition about all these issues that all of them seems to be a very general and a very important problem for a big part of the women in the world. We don't have exactly definition. It was difficult for me to understand really which one each of that disease. So I would like to know if we have a project to have a new definitions for all of these disease, and why don't we have any of them?
So I think, thank you, Javier. It's really interesting what you mentioned here, and it's very difficult to measure something that you don't have a good definition. And I remember when we were sitting together, always we were a little bit frustrated to know, okay, what we're looking, what we're running after. For example, what is this laxity? I think as a urogynecologist, I don't know how to define vaginal laxity. And this is all what I'm doing in my clinic. I see a lot of patients coming. Some patients say that, you know, the vagina is very wide. Some patients say that there is protrusion of the vagina wall. So how to define the laxity? This is only one example. GSM is well defined, so I don't think that we have a problem with the GSM. For sure, stress urinary incontinence, there is no any problem, you can define it well. But I think the main problem with the definition is the vaginal laxity. I know that there are different people who are working on how to define it better or how to measure it better. There are different devices which were developed in order to try to identify the elasticity of the vagina, because probably laxity is related to elasticity, something that you can understand better. But to tell you the truth, currently there is no one good definition that I can quote and I can say this is the best definition that we can use from now on. Therefore, the literature was very confusing for us with regards to laxity mainly.
Thank you for your answer. My other question and my other doubt about all of this is that when you review the literature, my feeling is that this works for selected patients, that we have to clarify for which patients is each treatment. And for that, we need randomized controlled trials. The problem here is that it seems that we are building up a house from the top instead of from the bottom of the house. So it is very difficult because we are building the science from the top, just going directly to the experience of the people instead of beginning in the basis and then randomized control trials, defining which population it works for. And my feeling is, I have no experience on this, but my feeling is that this works, but you have to work to define which treatment for which patient is it working. I think that both of them has a space in the to treat this kind of woman, but we have to define for which patient. Do you have the same expectations on the same experience I have when I am searching the literature?
Yeah, I'm laughing because it reminds me very much, because you're an andrologist, so maybe you can identify with me. It reminds me very much the shockwave.
Absolutely right.
Because I think the shockwaves and the shockwaves, I'm very proud about the shockwaves because, you know, I always remember the story how it started with Yoram Vardi, and he tells the story about how he started about it. And then everyone thought that this is the best treatment for all the ED, and all patients can benefit out of this. And I remember that during our conferences, there were so many different companies selling the shockwave. And then more and more studies started to try to identify who are the patients that can really benefit from the shockwave. You can tell us better. And it's the same with the laser. Laser started like a big boom, and there are many companies. I know about many colleagues who purchase this device for their clinic because they gain a lot of money out of this. This is a very good business. And a lot of, you know, rep are around us trying to sell us these products. But therefore, I think that by your leadership, it was very important to come with this statement and to say, hey, hold your horses, more research is needed, it needs to be established. Maybe it's not for all patients. Let's find who are the group of the patients who can benefit. And I find the similarity of these two very much. So therefore, I'm very happy you said this, because it was very important for me also to say as a statement. This position statement just came on time, I think.
I completely full agree with you. It's exactly the same we did with the shockwave lithotripsy for penile enhancement for erectile dysfunction, and it's exactly the same. And I think it is important in the next future, you are designing randomized control trials to define for which patient this works, because it seems it works. And to say the patient, listen, this is good for you. These are your expectations. This is not for maybe for this very important stress urinary incontinence, but for this mild urinary incontinence, it will be good for you. I think we have other questions coming from the audience. I don't know if you can see them because you are the expertise here. I just wanted to highlight this, and can you see them or not?
Javier, can you read them to
Absolutely
Leo?
right.
Yes, yeah, I can see. Okay.
We have a question with the licensing of ospemifene. Do you feel the use of these modalities of laser of radiofrequency will have less of a place in the management of this kind of patients? I don't know if you have any experience in the ospemifene that this colleague is asking us, because I have no idea about that, to be honest.
No, rather me. I don't have. I have to say that I don't have any experience, so I can't comment on it. No, I'm sorry.
Yeah, in Israel, ospemifene is still not available, to my knowledge. Just is a SERM, which is a moderator with estrogenic effect, but it's not directly estrogenic, so it's more selective. But I know, Leo, in Israel, you don't, it's not allowed yet, so you don't have experience with that.
If I can add a comment, Kobi, if I can add a comment, essentially the real answer to these questions is what Leo was saying at the beginning. So we don't need on which kind of patients this device can work. So maybe there will be also the possibility to combine the ospemifene with this kind of treatments. We need to identify the specific group of patients which can have more benefit for this treatment, and maybe obviously ospemifene works very well in some case, in some group of patients. So, but still we need to better clarify our population. This is my feeling.
Totally agree. Totally agree with you, Giovanni.
I completely do agree with you, Gio, that it is there is a very open window to include all these treatments and all these new devices that we are having. There is another question that is asking is, with regards to vaginal rejuvenation, does laser cause more scarring than radiofrequency? And so for women still wishing to have more children and deliver vaginally, maybe radiofrequency is better to offer than laser therapy. Do you have any experience of this, Leo?
To say that, for women who really wish future pregnancy, I would be very careful with using any vaginal, any of these treatments. And this is because I think that we don't know what's the real effect and what's the real long-term effect. And just let's think about the scenario: the patient has a treatment, and then during delivery, there is some problem in the delivery, and then she has a big laceration of the vagina during the delivery. So maybe then she can claim that part of the elasticity was lost during this treatment, and that was the cause for having a tear and laceration and a perineal tear that may result finally in fecal incontinence. So any of you who think to use it, I would prefer not, I would recommend not to use it for those who did not finish their pregnancy program, because I think that it might be a problematic in the future, mainly with regards to the lawsuits that can follow following this thing. So just think about it. So I cannot recommend on radio frequency rather than laser, because I think that it might be risky to use both of them for those women. But I'm interested to hear about what do you think. It's something which is, it's not related just to obstetrician. It's more about, how we today needs to think in the legal world.
Well, it is not only a legal aspect, it's also a common sense that it is very important in our daily practice. If we don't have any experience on that and we don't have data, it is risky to put people that can be having a damage on this without any experience. And I think that this scenario, I don't like it very much. If we don't have experience, if we don't have trials, I don't do this practice, but if I have to do it, I will not put a young patient on risk that is going to deliver in the next future without any experience on this. I think it shouldn't be done. There is another question that is asking us, in your experience, is it possible to placebo control laser studies? Patients seem to indicate that they experience discomfort with the actual laser, so how would the some laser experience compare? This question is a good question because it brings us this issue, but in the majority of the studies with these devices, like in the Shockwave devices that we are using, many of the effects of the devices are impossible to do to the patient. So sometimes you do the noise, you do something similar like when you are delivering the treatment, but are things that you cannot do exactly in the same way. So this is a good question, but of course it is difficult to do to the patient to experience the discomfort that you can suffer with the laser. I don't know if you have experience with these kind of placebo devices, Leo. Do you have experience?
We are currently conducting a study in my department about it. And so I have to say, the first thing, patients also feel discomfort from having just a probe in the vagina. And since patients do not know what to expect for, so they might think that they have the treatment, because the whole procedure, inserting of the probe into the vagina, rotating the probe in the vagina, can also cause some discomfort, and patient may think that this is because of not just the probe, not just the mechanical effect of the probe, but because of the discomfort in that area. So since patients do not know what to expect for, I guess that some patients will feel that, I mean, they would be really confused if they had the treatment or did not. Also, with regards to the noise, I agree, you know, noise can be done in a different way, but of course, it's never going to be the same, right? Because
Absolutely.
but since we think about placebo, so patients not always know what to expect, so I expect that it's the best way that we can do it, but there is no other way to do it, probably.
Absolutely right. Kobe, do we have time for one more question or not?
Let's do the last question.
The last question, Lior, thank you very much, because we are pushing you a lot. So thank you very much. It's a privilege to have you with us with all your expertise. So the last question is, thank you so much for a great presentation. Any comment on ultrasound use for vaginal rejuvenation? Do you have experience with ultrasound? I have to say that when we were doing the search to do the review for our statements, we found a lot of works with very different devices, not only laser therapy, not only radiofrequency, but also many devices, even with stem cells, with plasma, with many things. So I don't know with ultrasound if you have experience. Leo, do you have experience?
Yeah, actually, we have a study that we just completed, and we are going to submit it soon. And this is about the use of ultrasound for pain to treat dyspareunia. I don't know about, you know, I didn't find any study about vaginal rejuvenation or about stress urinary incontinence. I'm not sure that exists, so I don't remember from my heart, and I don't want to say anything about stress urinary incontinence. But for pain, I know that this is something that is really interesting, and I think that it needs to be investigated more. Though we did the first studies that in our group we did with Ilan Greenwald, but I think it's just the beginning. I think it's not well established like the laser or radio frequency. It's something that needs to be well established, but it's very interesting, and mainly for pain. I think it might help, but you know, just the beginning of the research.
Thank you. So first we end this webinar. I would like to thank once again to Lior for his expertise, for his work, and for his generosity. And also, I would like to say that Gio Corona, Kobe Reisman did a great job to develop all these statements. They work really hard. They are the arm of these statements. So thank you for your time and your hard work. It's amazing to work with you, learning and seeing all your capacity and your time. So thank you to all of you for including me in this project. And that's it. I don't know if Kobe or Gio want to say anything else. For sure, Lior has to say goodbye because he's the protagonist here. So please go ahead. Thank you very much.
Thank you, Javier, and thank you again, Leo, for a great presentation, and thank you, audience, for being with us. Just to do 2 remarks, soon the webinars will be available on the ESSM website. We we are recording them. There need to be some editing work, and then they will be available. Keep in track on our website and our newsletter, because soon there will be an announcement about the upcoming Congress in February, or I should say the virtual meeting in February. We postponed the ESSM school from November to April, so follow the announcement on our website and the registration to be at the ESSM school or the advanced course. And I promise you that our President Carlo, with the executive committee and the scientific committee, are organizing another series of webinars in the upcoming months. So keep track on all our educational activities that are organized. And last but not least, please write on the feedback what you think from the webinar, but also what you would like to know more that ESSM will organize. And again, thank you very much for being with us. Thank you, Leo. Thank you, Javier. Thank you, Giovanni. And of course, thank you, Carlo, for supporting all this project. And thank you all the audience for being with us. Have a good evening.
Thank you. Bye-bye, everybody.
Thank you. Thank you.
Bye-bye. Thank you.